right now. American Come on in, everybody. Come on in. We have seats available still. Please come in. If you have an empty seat that no one's sitting in, try to close up and use all the seats. We're going to be very, very full tonight. I feel like I'm on a flight. And anyone is still standing at the back, we have more seats down the front over here. A few I can see. Feel free. All right. Now we have a very well-behaved crowd. Everyone got in here on time. Thank you for obeying the cowbell. Want to kick it off?
Yeah. Hello, everyone. Hello. Thank you for being here tonight. And we're going to go ahead and get started. So welcome to the 3rd annual Boston Scientific Connected Patient Challenge Pitch-Off. We're honored and excited to see the community growing and growing every year. This year, the challenge has focused on the Internet of Things and how it encompasses the connections between sensors, devices, patients, and clinicians. By way of introduction, I'm Jennifer Joe.
I'm Jim Ryan.
And we're the co-founders of MedStro and MedTech Boston, the organizers of the challenge, and will be your MCs for the evening. We're so excited that Boston Scientific is invested in the medical innovation community and is the sponsor of the challenge that has culminated in this event this evening. You are about to watch 6 finalist teams pitch off in Shark Tank style.
Yes, although I have to say we're not affiliated with Shark Tank, the TV show, in any way. Any lawyers in the room? Yeah, so we have the 6 finalist teams. The first place team will take home $35,000 in services from Boston Scientific to help them make their product a reality, as well as 15,000 Google Cloud credits from the co-sponsor Google. The second place team will take home $15,000 in services from Boston Scientific and $10,000 in Google Cloud credits. So thank you to Boston Scientific and Google for providing those prizes.
So you're about to watch 6 lovely finalists pitch off. How did we come up with these 6 finalist teams? We all know that innovation in healthcare today doesn't happen in a silo. It's an open dialogue, a collaborative process, a building of a community. And for that reason, Boston Scientific launched the online interactive portion of this challenge in September of last year. So for over the last 6 months, clinicians, engineers, scientists, patients, and entrepreneurs from all over the world submitted their ideas for using the Internet of Things to improve patient care, increase efficiency in delivering of care, and drive down the cost of care.
And one of the really unique things about the challenges that we run and the Boston Scientific Challenge as well is that it's social. If you've visited the website where people submit their ideas, there's collaboration. Our online judges, we had 15 online judges from various walks of life with different expertise, and they provided comments and feedback to the entrants to help them improve their ideas. The general public also participated in that process. And then all of you. We had over nearly 2,200 votes. Voters from all 50 states, from 87 countries around the world voted on the submissions that we received to the point where we could narrow it down to the 6 finalists that you'll see tonight. The website that hosted the challenge had almost 9,000 followers, people following the updates from the challenge, and over 105,000 page views over the 3 months of the challenge. So it's been very popular. I want to thank the online judges, some of whom are here tonight, and Boston Scientific for contributing to innovation and for helping us choose the 6 finalists that you'll see tonight.
So thank you to everyone to making this happen. Yay! So we're about to get started. we're going to hear a few words from our keynote and the father of the Internet of Things, if you haven't met him before, Dr. Joe Kavader.
Thank you, Jennifer, and thank you all. The question I want to contemplate with you is, how will the Internet of Things affect the healthcare that we all experience? Now, you know it's going to be profound, because by 2020, there will be over 20 billion everyday objects around us that we now consider inanimate, but they'll be connected. And you know the drill, because you've all seen the Nest thermostat. You've seen how this works now in many different iterations, whether it be Amazon's Echo, what have you. The things in the Internet of Things are exploding. It really hasn't hit healthcare yet, but this is something that I've thought a lot about. In fact, in 2015, I published a book called The Internet of Healthy Things, and the first chapter is a vivid description of how this might look. So we're going to go 5 years into the future, briefly, and let me just make sure the slides are up. Yeah, 5 years into the future, briefly, and I'm being followed by a virtual health coach called Sam. Sam is part of a health benefit from my employer, Partners Healthcare, and I've exchanged a lot of my personal information to make Sam much smarter in guiding me through healthy behaviors in exchange for a premium discount. Now, the other part of this story is that about 5.5 years hence, my daughter's going to get married, and I'm trying to fit in to a tux that I bought right after I graduated medical school. This is a little bit of a challenge. So Sam is helping me make choices so I don't end up showing up at my daughter's wedding like that. But hopefully a little more James Bond-like, more like that. And you all know these are little choices you make every day. So Sam follows me around and says, no, I don't eat the cookie after lunch. You know, trade that in for a glass of wine at dinner. Or, do you know your office is right near the Boston Sports Club? You could actually swim. You could go over there and swim, and there's some people on your Facebook group that go over in there and swim. Maybe you could do something with them, or reminds me to take an extra walk in the evening if I haven't made my 10,000 steps. Little nudges like that. And then bring my daughter in, who says things like, Dad, I'm so glad you didn't have that cookie at lunch. Good job. That's how healthcare might come about in 5 years or so with the Internet of Things. So Sam is informed by all these wearables, by my GPS activity on my mobile device, by, again, the things in my Internet of Things, and that's what makes my personal profile so exact that Sam can coach me in a very specific, highly personalized way, and that's what makes it work. Now, you all know that we're not quite there yet. We've got a lot of things. We've got some efforts at analyzing them and even some interesting engagement, but we haven't put it all together. And that's really what I spend my precious few minutes with you talking about, is how do we get to that future that I just described. And I break it down into 3 areas. There's something about the Internet of Things part, the things, and the data they give off and how we deal with that data. There's a piece in the middle that we all love called analytics or deep learning or artificial intelligence. Choose your term du jour. And then my favorite, personally, because I'm a healthcare provider, is engagement. If I know everything about you, but I can't reach you and help you change your behavior, it's really pretty useless. So engagement is all about that psychology, right? So let's walk through each one of those quickly. There's a lot going on. Now, data aggregation and normalization is a really big problem. I can display my weight that I take on a smart scale, my activity level, of course, from my Fitbit. I can even put my data into my FitnessPal and show all those on one screen, but they don't tell a story because we haven't normalized them yet. So we're working on this, some of us, and there are companies working on it. We have a relationship with a firm called Validic, actually in healthcare delivery, where we've normalized some patient devices, and you can see that on the bottom of this chart. We allow clinicians to invite patients to bring in their consumer Internet of Things devices and bring those data in and display them in the electronic record as part of their care process. So we're doing okay at aggregation, but the normalization isn't there yet. I'll come back to that in a minute. A very short window into this data aggregation normalization challenge. In terms of new sensors, well, there's a lot going on. And most of them, I would say, it's all about giving you some sort of insight as opposed to the first generation, which were all about giving you a number. And they were invented by engineers, for engineers, or for quantitative people like me. I was excited to track my steps. Found out that most of my patients don't really care. So insight's important. And this is an example. Spire, you wear it, clips onto your belt. It measures respiration, which, unless you're a pulmonologist, is a really boring tracing. But they report out on focus, stress, clarity, that it's pretty accurate. So that's an example. And then, of course, Empatica, which is really even more exciting. An MIT spin out. This ankle-worn device will be able to alert this child's family if she's going to have an epileptic seizure 30 minutes before she seizes because of the galvanic skin response and the algorithms they use to predict that. So that's pretty impressive, and there's a lot going on. These are just two examples, again, because my time grows short. What's left to do? Well, we need to do better at normalization. I said that. We need to do better at frictionless. Our patients don't put up with pairing and Bluetooth and apps and all that. Just the data has to flow. We need to do better at that. And then our integration into clinical systems is still really what I would call kindergarten level. In the middle part, we have analytics. Again, everyone's favorite topic. The state-of-the-art analytics today is 100 people like Joe like this book, so maybe Joe will like this book. That's not going to fly for healthcare coaching. It's too personal. Now, one of the things we did in our team, and a number of folks from our team are in the audience tonight, we worked with Samsung to put this app together where we take a number of data points from an individual and send them a daily inspirational message to improve activity. We know it's working. We've tested it in type 2 diabetes and shown that we've improved diabetes without human interaction using this algorithm, and we're now finished testing it in some other chronic illnesses. So I think this can be done, and I think there's a lot of potential if we can get the analytics to the individual level, not 100 people like me, but me. And the Internet of Things allows us to get that really personal digital fingerprint, so we can do it. Lastly, engagement, and I said this is my favorite. I'd actually like to spend 10 minutes on engagement. I don't have that time. We use 3 strategies. We talk about this. So the first, make it about life. That's why my story was about my daughter's wedding. It wasn't about my doctor saying, if you don't lose 5 pounds, you're going to get a heart attack in 10 years, right? We've got it all wrong. We have to go with things that are really relevant now. Personal, I talked about that already. And social. Social is incredibly important. Anyone who designs a mobile app these days, the engagement includes social. It's just natural. Healthcare, we haven't quite got there yet. And then, of course, 3 tactics as well. One of them is about subliminal messaging, which means simply, your healthcare message ain't that sexy. Get it underneath something that really is, and we've shown that this really works. Another one is unpredictable rewards. And finally, the sentinel effect, which is really about, it's a subset of social. It's about the fact that if you know someone you care about is watching you through those things in your Internet of Things, you're going to behave differently. And we like that because as healthcare providers, we think you care about what we think about you, and that's one of our, perhaps, unfair advantages as this market unfolds, the sentinel effect. So what's left in engagement? Well, a lot, frankly. There's the fact that nothing is designed well. We have a whole design team. We really think design thinking is critical, but right now most of the software we throw at patients, and certainly at providers, is terribly designed. I've talked about fitting into everyday life. I've talked about personalization, and I've talked about the sentinel effect. Those are all things that need continued work. Now, last comment, why is this not an option? It's not something that we should think about as, oh, that's interesting and maybe. And here's the reason why. We've already passed a threshold. By 2020, there will be, for the first time in history, more people over 65 than under 5. And you know how that trend is going to continue. By 2050, twice as many people over 65 as under 5. And the over 65 cohort needs a lot more healthcare services. This graph is an illustration of how you feel when your doctor hurries you. It's an illustration of how your doctor feels when they feel burnout. The supply and demand curve is off. And all we offer you is, you have something, come and see me in the office one-to-one. If we can use the things and the Internet of Things and all these tools to start to do one-to-many, we can impact this curve. You will feel better cared for because, like my story with Sam, but your doctor won't have to be involved in every single decision, so she will be able to take care of more people at once. That's the future we have to get to, and I'm excited to hear the presentations tonight. This is my contact information. Thanks a lot.
Thank you, Joe Kaviter. Before we start the actual presentations, we'd like to give our live judges, or our sharks, an opportunity to introduce themselves to you. So I guess we'll go from my left to right, and please just stand up and tell everyone about yourself.
My name is David Fagan. I'm with Boston Scientific, and I'm responsible for digital health. Obviously, absolutely thrilled to be here at Boston Scientific. We are incredibly passionate about driving meaningful innovation, and there's really no more exciting space for us to be in than thinking, how do we leverage our devices? How do we leverage our devices, which are now becoming more and more connected, to improve patient outcomes, to really simplify the lives of physicians, and to improve the way healthcare is delivered. So absolutely thrilled to be here today. It's a great event, and really can't wait to hear the really passionate entrepreneurs figure out how to leverage technology for patient impact. So thank you again.
Thank you.
Wow, a lot more people in here than I thought. Hi, everyone. I'm Joe Corkery. I lead the healthcare and life sciences product team at Google Cloud. This is actually my second time doing this, so I'm really excited to be back to be doing this. I think it's a really great event. We're really interested in how we can enable healthcare providers, payers, pharma companies really do some innovative work in the healthcare space, especially through interoperability, data analytics, and machine learning.
Thanks, Joe.
Ooh, there are a lot of people. So my name is Howard Levin. I'm not with Boston Scientific, but I'd like them to acquire every one of my companies. I'm an engineer turned heart failure cardiologist turned startup guy. Have developed and sold 6 companies, and I'm very excited to be here. I wanted to, though, before we finish, make one comment. I'd like to thank the sponsors for providing the chocolates, which we shared, and just mentioned that the presenters should have been the ones that provided the chocolates for the judges. But it's okay.
Thank you, Howard.
Hi, I'm your last one. I'm Helen Montag. I come from Baltimore, from Johns Hopkins Technology Ventures. Really excited. You can feel a lot of palpable energy in the room. I would invite each and every one of you, if you are in Baltimore, please come see us, come see our incubator, come see what's going on at Hopkins and in Baltimore around innovation. I love to come to Boston. I was educated in Boston. Really excited to see what you have going on here, but also come to the other city that starts with the letter B. Come visit us. Thank you.
Good. Oh, and thank you very much, judges, for the introduction. Before we start the first presentation, I noticed we have some people standing in the back. There are a few seats still available. I see a few here. If you have an empty seat next to you, raise your hand. If we run out of seats, there's an overflow room, which is if you exit the door here and go diagonally backwards through the other door at the back of the room, there's a simulcast going on there if you'd like to sit down. Anyone still waiting for seats? Please feel free to filter down to the front. And we've got people raising their hands over here. Excellent. OK. So while we're arranging the seating, I'll take the opportunity. So the format, a lot of you have been to our events before. The presenters have exactly 5 minutes to present. We actually cut them off after 5 minutes. And then the judges will have 5 minutes for their questions. So without further ado, I'm going to introduce our first team representing AI2 Merida, Ramya Palachula. Ramya.
All right. Good evening, everyone. Well, they say grandmothers are warm hugs and sweet memories. And my grandmother was no different. She was all of that and even more. But what changed my life as a young adult was when she was diagnosed with cancer. And she underwent an excruciating treatment period with multiple drugs until the doctors found the right one for her. But by then it was way too late, and she suffered way too much. And all of my positive memories and happy memories with her were replaced by dark ones of her suffering. The reason I'm here today as a clinician and a scientist is because it's not just my grandmother, but 40% of the breast cancer patients across the United States do not respond to the chemotherapy they're given in the hope of saving them. And that's a problem, because breast cancer today is more of an art than science. And when you give the patient a drug they don't respond to, they have way too many side effects, most of which are even worse than the disease itself. And not just that, the healthcare system incurs huge costs, up to $2 billion a year, to treat that 40% with chemotherapy. But if you somehow could give the patient the right drug to which they respond, the patients have been shown to have fewer side effects, improved quality of life, and are 7 times less likely to have a recurrence. So a team of us thought to ourselves, if Google can tell us what we're going to type into the search engine in the next minute, and the Amazon can tell us what we are going to buy in the next 4 days, why can't we use predictive analytics to save patient lives? And that's how, ladies and gentlemen, AI2 Merida was born. This is a data-driven model that can predict the probability of a complete response with a particular chemotherapy in individual breast cancer patients. And this is currently being developed using advanced deep learning methods and data from 100,000 breast cancer patients receiving care over the last 10 years in the Partners Healthcare system. And this will be extensively validated and integrated with EMR, and will be a continuous learning model that will learn with new data from the EMR. So let me explain how this works in a healthcare system or a hospital. Simple. It is housed on the Google Cloud platform, which will communicate with the EHR to harness complex clinical data and present to the clinician actionable and patient-specific probabilities of response to chemotherapy in a clinician interface like this. So when the patient is with the doctor in the room, they can sit together, come up with a very customized plan that will help the patient achieve a complete response and increase patient outcomes. And this is a great advantage because you're giving the clinicians the ability to do what's best for their patients. And this is not often possible even with years of experience, because no human being on this earth can predict future, but the machines can. So if this system makes it into the healthcare, and we're looking at just maybe costs for 10,000, a subset of patients, and you're able to cut down one unnecessary treatment, you can bring about cost savings of about $30 million, which is humongous in comparison to what it costs to develop this algorithm. And this value proposition has resonated very well with world-class Research Medical Center, who are our partners at like Northeastern University and Harvard Medical School. And this has given us a unique opportunity to work with a multidisciplinary team that has a proven track record of building and implementing complex clinical decision support algorithms in partnership with tech and healthcare giants. And these algorithms are being currently commercialized. So ladies and gentlemen, this is an innovation that can solve a huge problem and save and improve lives of millions of daughters and mothers across the globe and across the United States, including yours. So join me, Ramya Palachola, and this amazing team to Merida here in radically changing the way breast cancer is treated today. Thank you very much.
Please sit. And judges, feel free to ask any questions you might have.
Okay. Very nice presentation.
Thank you.
Nice shirt.
Oh, thank you.
So, you know, of course, this is a very important project, great thing you're doing. But is it a research project or is it a business? Is this something that's good for mankind or womankind? Or are you actually, I don't see, once you have figured out the answer and published it, how are you going to make money? How are you going to return, provide a return on investment to your investors?
Right. Thank you for the question. So this is currently being undertaken as a research study with multiple people in the team from Northeastern, Harvard, partners, everyone. So we're not a startup, but we've come together to build this product. But where the most return of investment would be is, of course, in terms of patient outcomes. And we're hoping that along with saving lives, we save money as well for the healthcare system because these patients cost a lot of money, those who don't respond to chemotherapy.
Right, but why should a VC invest in this rather than NIH?
Right. So there is a lot of potential to scale this as a software across different healthcare systems and hospitals. So right now, we will choose one particular pilot healthcare system or a hospital to, once it's developed, we'll put it there. But I think there's a lot of global opportunity to scale this as a software.
So you're saying that the treatment in different hospital systems needs to be different. It's not, you're not going to treat breast cancer the same from Harvard to Hopkins to Farber to wherever.
So basically the treatment remains the same. What happens is with this solution, it gives the clinician sort of the probability that the patient will succeed. So ultimately, the clinician is the one making the judgment here, the judgment call on the treatment to be given to the patient. So it's not replacing the clinician or the clinician judgment.
So what are you selling? Are you selling an algorithm?
Yes, that's right. So it'll be the software that will be the key product here.
But what about this? Excuse me if I'm not understanding this properly. But it seems like you have a bunch of data. You're crunching that data, and you've come up with a population-wide answer based on all the different criteria for that particular patient of what the best therapy is for them.
That's right, yes.
You're saying that that specific algorithm is proprietary and the only algorithm that will predict that the best outcome for those patients. That there were no other algorithms that would predict that if I was a VC and I wanted to invest in somebody else's algorithm, it wouldn't be, I would be able to make money on that.
Right. So the key competitive advantage that we have is access to patient data. So this kind of a clinical algorithm cannot come to life anywhere else except in one of the largest healthcare systems in the country, where you have access to not just data, but a whole lot of it and quality and quantity of it in a centralized operational data warehouse that Partners is very proud of, which is the enterprise data warehouse. So that's what we are using to build this. So access to that data is something that other people, our competitors who are building similar algorithms, don't have. And the other thing the point that I will make is that such personalizing or predictive algorithms are being built using some genomic data and other things like that. But they're still in the initial stages. And this is a clinical model and has potential to integrate with the genomic data later in the future. But those are the genomic models are still in the initial nascent stages, and this is something that can happen pretty quickly because we have access to the data. We're already working on the data and coming up with what are the important variables.
What is it exactly? What is in the algorithm?
So the algorithm, it's a predict. So it's it's big. We're using big data and coming up with an algorithm. The outcome of the algorithm is the actual probability that the patient will succeed. So if the algorithm says that this patient will succeed, it will take the tumor-specific characteristics and the patient characteristics, and then based on historic patient data, it will give a score, basically, which is the probability of complete response. So what it would say is patient A or Joe or whoever will have 80% chances of succeeding on paclitaxel, for example. So it's basically, clinicians right now take decisions based on their previous experience and beliefs, so we're just giving them a powerful data algorithm to help them in clinical decision making.
So is your algorithm patentable?
Not yet, sir.
No, not patented yet. Is it patentable?
Yes, absolutely.
And how do you know that?
So I know that because from my knowledge, there are currently no existing validated algorithms that are being used across the country to predict the response to chemotherapy. So, if we're first to finish developing and validating this in the healthcare system, we can definitely apply for a patent.
And what kind of early indications do you have that this works, that there's enough sufficient relevant data in the EMR records to have a correlation with outcomes based on the treatment?
Absolutely. So, I think there are two key things to build such a model. One is the quality and the quantity. Right now, we have a lot of quantity, and we are exploring the quality of this data set. And, this is a very rich patient data set, so we're hoping and we're very optimistic about the fact that the data set will have the quality as well as the quantity.
So, how do you plan to interact with the FDA?
Excellent question. So, I was maybe expecting that even. So the FDA has released some guidelines about software as a medical device. So where the software is replacing the clinician and giving out decisions on diagnostics, decisions on treatments, that needs an FDA approval. But this algorithm is unique because it gives the necessary information to the clinician but does not replace the clinician's judgment. So it does not require actually an FDA approval. So what is required here is for us to prove that this works in the healthcare system, can be easily implemented, and we can take it from there.
So what if I was at Dana-Farber, or what if I was at MD Anderson or at Hopkins Cancer Center, and I got a bunch of really smart people like yourselves together, and they churned through all of their data and came up with another algorithm? Why should I use your algorithm over, granted it's Harvard, right? Okay. But why should I use your algorithm over their algorithms?
Right. So I think the first thing is, right now in the market, there aren't any that are being validated. So we have that one advantage. So we're already in the development stage and can get to validation pretty quickly about this. The other thing is, I think this kind of a software has a large impact on the patient, and we have the testing ground for it. So right now, we have strategic partnerships with Northeastern, Harvard, and Partners Healthcare System. So what happens here is we have the testing ground, we have great testing ground, so that's our major advantage over the other people. And I think these, like Dr. Kaviter said, it's not just enough to say this 100 people did this, so this is the right thing for the 101. It's important to prove that what you're saying is correct. So I think that is the advantage we have over the other people who may develop such algorithms, but the validation of these kind of algorithms or softwares is just as important as developing these to prove outcomes.
So I'm sorry, we've run out of time for judge questions, but thank you very much, Ramya.
Thank you, Doug. Thank you, everyone.
Excellent. Thank you for all the great questions. Keep those coming. Our next team to present is from Ines Care. Please welcome Donald Garrison.
Good evening. First off, I want to say it's great to present to a group of people like this that have a passion like I do for connected health. I'd like to congratulate the other 5 finalists, and also thank you, Boston Scientific, Google, MedStro, and MedTech. Eins is a German term, and it means one, and we're a group of healthcare IT professionals that's focused on care for healthcare, and so hence the name Eins Care. Our initial focus right now is bringing to the market improvements in targeted patient adherence. These are strategies that guide, remind, motivate, and engage the population to follow medical or healthcare recommendations. Not following medical advice can be a major threat to health and well-being, and we also know that the costs associated with that can be significant. This is particularly true with our aging population. Interestingly enough, elite athletes are among the most disciplined when it comes to some sort of daily regimen. So our first entry in our concept is in the area of the sports world, and we're looking at something called off-field analytics. What we mean by off-field analytics is what they do to prepare and get ready for a game and what they do after a game. We can learn a lot, and we can learn a lot about what their personal peak performance levels are and how they got there, and there's a lot of success factors. Tom Brady, 40 years old, just competed in his 8th Super Bowl. He had his best performance yet. How did he do this? What is he doing different that others are not doing? We think that there's lessons to be learned from this. And I'm not here to talk about the TB12 methodology or anything like that, but we think that success leaves clues. And there's some best practices that we could apply here. Currently, there's 5 off-field analytic areas that we're looking at. The first one is exercise and workouts. The second is their diet and hydration. The third is cognitive performance, and the fourth is rest, and then finally recovery. There's a correlation between these off-field activities and best practices and daily routines that can be applied that will improve patient adherence. Our solution, as you can see here, enables increased adherence through suggestions, best practices, and notifications leveraging RPM, or remote patient monitoring, with all the stakeholders involved. For an athlete, the stakeholders would be a coach, a trainer, and a physician. But outside in the real world, outside of sports, an application could be for our aging population, where the stakeholders could be a family member, referring physicians, specialists for monitoring whether mom or dad are doing well and how they're doing today, and did they take their medications. It's trying to get them to be more engaged. There's also use cases with the youth and teenagers that we'll be exploring later on. This holistic viewpoint of the off-field data points plays such an important role in the on-field success of elite athletes that we believe our vision is to apply these in real-life scenarios so that we can all be at our best. Phase 1 is where we are right now. We're customizing a training regimen designed for elite athletes and remotely monitoring by the key stakeholders that they have. Phase 2 is coming up very soon and will be applied to other sports and activities, but also to our aging population. Phase 3 will get into disease management, solutions, and RPM. The algorithm is the same, the data is different. Phase 4 will be the development of additional wearable devices. So what if we could assist our aging population in being more vibrant? What if we could assist our aging population in living in their 50s, 60s, and 70s like they did when they were in their 20s and their 30s and their 40s? 10 years ago, I summited Mount Kilimanjaro. Why can't I do that 10 years from now? The more active we are, the more engaged we are. The more engaged we are, then the more we'll adhere to what is being recommended, resulting in healthier lifestyles, longer living lives, full of vitality. That's what I want. I think that's what most people want. It's all about applying best practices in sports and applying the general population that will improve health. Eins Care will save lives, and it will save money. Thank you.
Questions from the judges?
So what data are you actually collecting?
So we're collecting data on the 5. Who asked the question? Okay, sorry about that. We're collecting data on exercises, the types of exercises, how often they exercise, the types of routines, workout routines that they're doing. We're looking at their diet and nutrition, what they eat, when they eat, how often they eat as a percentage of their body weight. We're looking at the same at hydration, what they drink for hydration, when they drink as a percentage of their body weight. Cognitive performance, how do they get themselves mentally in the zone? How do we get ourselves mentally in the zone Monday through Friday, right? And then rest and recovery. What are they doing so that they can get ready for the next event? What can we do after we've lived over the weekend and want to get to work on Monday feeling normal?
So I guess my question is, how are you collecting that information? Is it devices, self-reported? Where's that coming from?
It's a combination of both. It's devices and self-reporting.
Okay.
When you think about, almost by definition, elite athletes, they're highly motivated.
They are.
The challenge in adherence is actually motivating those patients. So how do you help me understand the correlation between a highly motivated person who maybe you're helping optimize versus somebody who is unmotivated, getting them to become motivated?
Sitting on the couch.
Yeah, and do you have any view on the impact? Have you seen this happen? How does that work?
Yeah, I mean, it's still early stage, but I mean, what we're viewing right now is that there are some critical success factors that you can transfer over to the aging population. It's the notifications, it's those kind of regimens that they do on a daily basis that we think is going to help them, to remind them, to motivate them. And when they start to see some success, they'll start to get more engaged. And the more they get engaged, the more they'll do. We think that's where they'll start to save lives. They'll start to take their medications, et cetera.
Yeah, I mean, what you're proposing to do is that, clearly an important thing, getting the aging population up and running. I see absolutely no evidence that what you're saying has any truth whatsoever to it. You're not showing any data on it. You're not showing anything. So the question is, if I was a VC and I was going to come in, I could see how you can make Tom Brady better to the detriment of my New York Giants. But that aside, I'm trying to figure out, why would I invest in your company in terms of the potential upside and in terms of how you're going to protect what you are trying. Why is your way the best way to do it, and what sort of protection do you have that would stop other people from coming in?
Okay, so that's a two-part question. So first of all, we're applying best practices to this, and it's going to evolve around how much they follow your instructions. But we believe that based on some of the best practices that we're learning in the small samples that we're doing so far, we're starting to see the results. Again, we're doing this with athletes that are not at the elite level. Now we're going to take it to the aging population as well. We're still in the early stages of the sampling. What was the second part of the question again?
Just how would you protect that? How are you going to prove to a potential investor that you can protect this against other people coming in?
Sure. Well, so what are the barriers of entry? I think what we're looking at is the differences in the algorithms that we're using right now. So, that still remains to be seen because we're still early stage, but I think it's going to be the software and the algorithms that we use.
I don't think that you can protect algorithms and software. I think you can copyright them. I don't think you can patent them.
Correct.
But what's the deliverable? I'm having a hard time envisioning. Is it an app?
So the deliverables are I'm a referring physician. It could be a dashboard on my patients. I'm a parent. It could be a dashboard on the activity that my son or daughter did today, instead of sitting in front of the TV. If I'm a child of a elderly parent, it could be a dashboard that I'm getting that mom and dad did take their medication, or they didn't take their medication. They did some activity today. They did record it's going to rely on some of the recordings and them adhering to entering information in. But we think that there's a lot of good evidence for that.
It's a very broad set of things you have going.
Yeah, there's another number of areas that we're going down the path on.
So how do you plan to deal with like the fatigue of entry? Like, as an elite athlete, I can see I want to track this every single day, but eventually you're going to be like, I don't want to care, or it's like, 10,000 steps today. It's like, well, what are the motivations that you're going to put in front of them?
For the aging population, no doubt it has to be easy to use, and it's got to be something that's very simple and one or two buttons or clicks on their device. The younger population, they're used to using that today. They're used to using that type of technology. So,
I guess it's definitely true. The younger population is used to using it, but like the younger population doesn't need it.
Right.
It's like, how do you motivate the older population?
Well, actually, that's a little bit debatable, but yeah. I think the younger population today is not as active as they used to be.
All the time we have for questions. Thank you. Great, thank you. In the interim, we still have people standing at the back. There are seats available. Feel free to filter down and grab a seat. Next, representing our next team, Am I Aware, is Leah Amir.
I'm excited to be here this evening and discuss with you the technology that we've been developing for about 3 years. We have a patent around our device and around some prognostic markers that are going to help us all stay alive and avoid that first and fatal heart attack. Every 43 seconds in the United States, someone is having a heart attack. I'm sure you can maybe relate to that. And tonight, I want us to think hard about how we can change that. I think we have the right solution. For the first time, our device is able to deliver to the emergency room an efficient, fast, multiple marker methodology to rule out or rule in those patients who are likely to have a heart attack, or they're having a heart attack today, are likely to progress to one over the next 6 months. Specifically, the need is significant. There's over 9 million patients presenting to the emergency room requiring a rule in, rule out, or yes, you're having a heart attack, or no, you're not. There's at least 92 million suffering from cardiovascular disease from a prior heart attack or with vascular disease that has not yet progressed to that degree. We know that over 700,000 people every year will have a heart attack, and for those and for many, it's their first and fatal. I'm sure you can relate. You probably have some family members that can tell the story. I didn't know, or he was perfectly fine. But there are a series of events that go on before that happens. In fact, we know that about half of the sudden cardiac events that occur outside the hospital. And we know that, therefore, the patients who have heart disease are not acting on the earliest warning signs. That's exactly where we sit. We're using a multi-marker approach with prognostic markers patented and licensed from Leiden University, the developers, to be able to identify plaque rupture that will actually lead to a cardiac event. Today, when a patient presents to the emergency room with chest pain, the doctor is immediately faced with a very important and needs to be rapid decision: are you having a heart attack today or not? Those that are obviously positive are relatively easy to decide, admit, take them down the protocol pathway. But those that are in the gray zone are not that easy to determine. And today what we do is what's called repeated measures of cardiac troponin, which is a measure of cardiac tissue death. And if those patients aren't yet in their heart attack, like, doc, I know I'm having one, come back tomorrow, because their cardiac troponins will not be elevated. So what happens, there's increased cost, increased ER weight, resulting in over $30 billion annual in U.S. costs just for the triage, not even treatment. We're providing a preventative opportunity to reduce the first and fatal heart attack. Today, what you see is a graph, and we're showing you the traditional markers measure cardiac tissue necrosis. This is after the heart attack occurs. Cardiac troponin doesn't actually elevate until 12 hours into a cardiac arrest. And some of the high-sensitive cardiac troponins are somewhat subjective in that you might not have actually had a heart attack. You could be an aggressive athlete, and you could show positive. So in fact, high-sensitive cardiac troponin is creating problems, wherein some of the doctors, such as at the Mayo Clinic, are saying, please, we'd like these multiple markers. We need to refine this information. And that's exactly what we're doing. We're looking at plaque rupture. The scientists associated with this from Leiden University have been studying coronary plaque, plaque rupture, and remodeling for years. There's tremendous dollars that are behind the work that we have done at this point. We're offering a cost-minimizing approach to reducing inpatient admissions and reducing the incidence of invasive tests. And we certainly believe that by properly monitoring the patients in the physician's office or when they come to the emergency room and they leave with better information, we can avoid this first and fatal or repeat fatal out-of-hospital cardiac arrest. When patients are measured using our device, AMI Aware, they'll leave the hospital with discharged information that they can use to follow up with their physician that is informed, focused, and allows for a positive follow-up. We're bringing precision to the emergency room like never before. I've worked in labs. I'm a scientist. I always say scientist first, healthcare economist second. I know what it's like. I know the cost. I know the time. We've got 13 markers in triplicate compared to controls on our device, and we can report a heart attack that might happen, as I say, within 6 months. We can identify a heart attack in progress, heart failure, worsening of heart failure, tissue regeneration markers, as well as kidney function. And as you see, all we need is a finger prick of blood going into what we're calling our reaction device. On here, there's patented fluidics, and we have patents around our detection methods. Currently, it's being read by an iPhone, which lends itself well to our early prototyping phase. And we are planning a clinical trial with the Mayo Clinic to gather information to refine what is currently being used to rule in and rule out patients with a heart attack. Right now, we have an iPhone app, very easy to use. And after the sample is inserted, within about a 24-minute time, you get the answer on 13 very complicated proteins. And that information can be sent by email to any source that's identified for that. The portability is necessary. Healthcare is changing, and healthcare providers, as well as insurance companies, are interested in portability. We call it decision-making on the spot. ER is our first target that we will be going after, and we feel that it will be a natural advancement such that the ambulance should be able to have our product on board. We've tested our product for bouncing and agility, and it handles quite well. And they can call in the information. The emergency room can already know what the 13 marker panel is reporting for a patient at the time of presentation. Certainly for those patients that have had a cardiac arrest, in a very simple, low-cost manner, these markers can be measured at their bedside. And once this product is out on the road and we get more users, we're rather certain that it will be used in the physician's office and certainly in urgent care clinics for those people coming in with, gee, I'm not feeling so good today, but I really don't want to go to the hospital because it takes so long. And now it can be emailed easily to the emergency room if indeed there are patients that need emergent care. However, our goal is to keep patients out of the hospital, treated from the physician's office, treated with methods that prevent that first and fatal, prevent heart tissue damage, which is in and of itself significantly cost savings. So we're bringing to the market a very competitively priced, cost-minimizing solution that results in the first time real documented information for prevention of heart disease and the progression.
We're out of time for presentation. Sorry about that, and we'll move on to judge questions.
Thank you. Dr. Stuart Hagano will be responding to some of the clinical questions. This is Dr. Stuart Hagano. Thank you.
Well done. Okay. One thing I often see in this space is we talk about big data, but so often it's about that critical bit or the few critical bits and getting those critical bits to the right place so you can take action. And I think this is just exactly one of those critical bits, and you're generating that really very high impact data. So kudos to you. The question is really around a little more around the platform, and I mean, do you really need the iPhone interface? It causes challenges. Why is it important to have that mobile interface?
The iPhone right now is to read the reaction in our reaction system, and we are moving to an embedded sensor. So that's what that's for.
Okay, I was going to ask a very similar question of whose iPhone are you putting in there?
We actually, for our system and for our testing, we've bought separate iPhones. But that's why we're moving away from it for issues relative to Apple. We don't want to have any problems with them. And because we have, patents around our detection methodology, we're advancing. We just had to verify that we can get 13 markers to behave correctly in our reaction region.
Yeah, and I guess, so you had said that you initially were targeting the ER, but then you're also targeting like the physician office. If you deploy in the ER, it doesn't really matter if you can email it to the people in the ER. Where do you see it actually being used, front of line?
Well, I'm going to let Dr. Agano also speak with that, but I think in the ER is helpful because it's fast. It gets you in and out if you're negative within a 15 to 20 minute time period. And today, have experienced myself and family members, you're there for 8 to 10 hours or longer.
Yeah, I mean, clearly the initial use of it is for rapid diagnosis in the ER, as Leah mentioned, not only for diagnosing necrosis, but also early plaque rupture when there's inflammation in a plaque, and that's what the chemokine inflammatory markers will do. But when you think about the use in the ER and then moving beyond that, sure, the physician's offices. You might even think, and this is where this goes way ahead of where our current data would be, but home use. You have chest pain at home. The next step, urgent care, and then moving into the emergency room. But clearly the first data point that we have to look at is in the emergency room.
So what you're saying is you're going to theoretically let somebody put a drop of blood in there and not go to the emergency room because of that information.
No.
Well, as I'm saying, that's many steps away from where we are now.
Okay. So let me just ask you a couple of questions. So when is this performed? So if it's performed, how long after, on average, do you believe the initial chest pain started?
I think what we're focusing on is that patient that presents to the emergency room with uncertain, I don't know what's wrong, I've got chest pain.
Right. But are you in the troponin window at that point?
Probably not, because 90% of the patients are not in the troponin window. They would be in our window.
Okay, number two is, if for doing it in the outpatient setting or doctor's office, is there a chance of this thing being CLIA waived? Or, how are you going to get it approved so that it can be done in a non-central lab?
So I've had discussion with the FDA. My world is economics, reimbursement, and commercializing new medical products. Mm-hmm. And what we want to do is get FDA approval as a Class 2. We're going to do a de novo study, and that's the clinical trial we'll be doing with the Mayo Clinic.
Okay. By the way, I think everything you're doing here is great, and I really think it's an interesting approach. I think the clinical trial will give you the answer whether you're better or not than whatever. The point I want to bring up is this is $100 million in development.
Actually, we have spent about $3.5 million to this point.
To do the clinical, how much is this clinical trial? This is
I've got the
$30 million.
No, I've got the clinical trial budgeted. And
how
we're
many
not
patients?
Anywhere, 1,500 patients. We're twice the statistical significance because we're going to do subgroup analyses. And we are going to be measuring the multiple markers on a microarray kit that we have made in order to advance us to the reaction chamber, we call it. So we'll be measuring these. I mean, we've budgeted it out. We're at right now about $2.5 million.
This is the Mayo study.
And they very much want to do the study, so they could be being nice to us, I guess we could say.
Okay, but but to get FDA approval, usually you're not going to get it on one study. So what about that? Are the rules in Europe the same as the rules in the U.S.? Is the clinical pathway of care the same in both settings? What's the general pathway?
So the clinical in Europe, we get the CE mark.
By the way, would you like a piece of chocolate?
Not that healthy unless it's dark chocolate cardiac.
It's actually good dark chocolate.
Looks pretty good. Okay. But I could take this offline with you and discuss it further. But I've had a lot of discussion with the FDA on this already, and we've discussed it through what they call the sub-Q level. Is when you provide what your initial process is. I have a 3-step process with the FDA. The first is showing them my multiple markers and that my multiple markers in the kit are elevated in the appropriate manner, and I get repeated serial results. And then we've had a lot of discussions, and they're really comfortable with what I'm doing so far, and they know me. Not that that's a fabulous thing, but I've had good success with the FDA over the years, so I learned to get along with them a long time ago.
Well, really cool idea. I wish you the best with it.
Well, thank you so much. It's been a lot of work.
Thank you. Excellent. So we're halfway through our teams. I'd like to welcome next to the stage our 4th team to present. Representing Haptic, we have Amaya Naniva Dakar. Amaya. Thanks. Your mic.
Hi, everyone. I'm Amaya. I'm from Team Haptic. And I'm here with Santosh Chandrasekharan, who's also part of our team. At Haptic, we want to develop a wearable for sensorizing existing prostheses. In the United States alone, nearly 200,000 persons undergo amputation of an upper or lower limb for a variety of reasons each year, ranging from diabetes mellitus to dysvascular disease and trauma. And the number of people living with an amputation is expected to grow to up to 3.6 million by the year 2050. Additionally, in more recent times, up to 1,600 returning servicemen and women have returned with unprecedented rates of amputation and injury, rendering them permanently injured. And yet, more than 60% amputees abandon the use of their prosthesis. So we asked the question, why do people abandon their prosthesis? And one amputee gave us this answer where the prosthesis itself is expensive, it's an uncomfortable gadget, and it takes away a lot of function, most importantly, the ability to feel the world. And that's actually a common thread between the several amputees that we've talked to, the absence of sensory feedback. And so if you look at how prosthesis development has progressed, we've gone from simple cosmetic hands and feet to body part hooks and limbs to really dexterous controlled robotic limbs that are available for both research and clinical purposes. But none of these devices actually provides naturalistic sensory feedback, and so intuitive control of these devices remains elusive. And so the problem that an amputee using a prosthesis has to face is this same challenge of holding an eggshell with the appropriate amount of force so as to hold it but not break it. And so you want to detect object contact and regulate the grip force. So what we've seen in our research is that sensorizing a prosthesis, so adding sensors that gives you that information, improves the functionality or improves how an amputee can interact with an object. So in this case, if you added sensors to tactile sensors to the prosthesis, it provides sensory feedback and to some extent better control of the prosthesis. And so with that in mind, we came up with Haptic, which essentially simplifies the sensorization procedure. We want to be able to add sensors to existing prostheses and interface with any stimulation or feedback delivery system to be able to provide lifelike or near lifelike sensory feedback to the user so that it improves their control of the prosthetic device itself. So what does Haptic look like? Haptic, or the Universal Haptic Package, is a wearable for existing prostheses that can attach low-cost sensors with minimal modification to an existing prosthesis. It comprises of it's basically a universally compatible with upper and lower limb prostheses, and it comprises of a plug-and-play software interface, which interfaces with several different stimulation systems or feedback delivery mechanisms, which are invasive or non-invasive. So if you had to look at what a potential Haptic package would look like for the upper limb prosthetic, it would comprise of a wearable module that comprises of up to 6 sensors to detect limb state, pictured here as B, C, and D, and then the processor module that translates the sensor data or the limb state information into a feedback signal that is relevant to the prosthesis or the user of the prosthesis. And because we want it to be universal, we also want to develop the same package for the lower limb, which comprises the same sensors, but only differs in how it's attached to the prosthesis itself. So how do we compare to the competition? Well, currently, sensorizing a prosthesis is fairly ad hoc. So what you see on the top right is an image of how, in the lab, sensors are attached to a prosthesis. And you can see that it's basically taped sensors with wires running down the prosthesis. It's not an elegant solution, but it works. Or the other end of the spectrum are these really complex, expensive sensors, such as the SynTouch sensor, that work really well, but have a pretty complicated calibration process, and attachment to the prosthesis itself is fairly expensive. So what we want to do is make it standardized, plug-and-play compatible, and an inexpensive way to sensorize prostheses. So a quick look at our journey so far. I work at the Rehab Neural Engineering Lab at the University of Pittsburgh, and Santosh is a postdoc who's been working with upper limb amputees specifically. And we've shown in our lab experiments that sensorizing a prosthesis as a proof of concept does show some improvement in how a amputee interacts or uses his or her prosthesis. And so with that idea, we kind of applied to the Pitt Innovation Challenge and secured early funding to develop a prototype of the computers that we work with in the lab. And so we're hoping, as part of our participation in the Connected Patient Challenge, we'll be able to kind of take it from a prototype to an actual product and get some more user feedback and verification and validation from amputees out in the market. And so with that, I'd like to thank my team, and Santosh will also be up here to answer any questions regarding the actual research part of this stuff that we've been doing. Thank you.
My understanding is that one major reason that amputees don't like their prosthesis is that they have irritation at the stump. This doesn't address that at all. So it'll make them more sensitive, but they'll still have the problem. Is that correct? Yeah.
That's correct. So the idea of developing something that's universal is that we want to make the system agnostic to the type of prosthesis as well as the type of sensory feedback delivery mechanism. So sure, that is a valid point, but that's something that we're kind of offloading to people who develop prostheses.
Yeah, they can choose whatever prosthesis they want to use, and most of the times, yes, as you say, the irritation is a problem, but there are also other problems like this lack of sensory feedback. So even if they choose a better prosthesis, they have those other problems. We're trying to solve everything else, so they can choose something that works for them, which is not irritable or something like that, and they can have this advantage.
So are you then triggering the efferent pathway in a different way? Are you providing electrical stimulus somewhere? Is that also part of the package? And if so, have you seen that kind of adaptation over time where people learn how to use this?
Do you want to answer that?
Yeah. So our approach to this is we are agnostic to what they want to use as a feedback. It can be vibrotactile, electrostatic stimulus, or anything else that they want to use. But in our research, we have used electrical stimulus of the spinal cord in particular, and we haven't seen any adaptation, and they're able to use it very intuitively, immediately. And other research groups have stimulated other areas of the arm, the residual limb, and they have also seen that people can use that information.
Yeah. So I would say interfacing with the nervous system is inherently an invasive procedure. But if you wanted, you could also opt for, as Santosh mentioned, vibrotactors, which are or transcutaneous electrical nerve stimulation, which is less invasive, but still has the potential to deliver relevant feedback.
So, yeah, when I think about this, it feels like there's a lot of local feedback loops here. Like, how do you see this as being like a broader connected device, outside of the patient?
Right. So I would the most obvious impact from a research perspective would be to be able to monitor how the use of the prosthesis changes because they have this additional sensory feedback. So we believe that sensory feedback is relevant. The patient believes, but if we give them a sensorized prosthesis that does provide the feedback that they want, does it actually improve how they interact in their daily life? Does the use of their prosthesis, do they use it for longer? Do they use it better? And I think those sort of metrics are kind of the easiest way to kind of validate within patient whether it works or not.
So this is really cool. I like the idea. Let me put on a VC approach for a second. So the question is, what percentage of people actually care like the person that you said there? Is it that this is a nice to have and 1% of people, care about this, or is this, 90% of people, or do 90% of people have enough problems dealing with their prosthesis itself that this, they wouldn't even think about this on a daily basis?
So the thing is, they do not think about it in the daily basis. They get really good at using their prosthetic devices without the sense of touch. But the moment you provide the sense of touch and take it away, they are as bad as losing an arm all over again. People have actually shown this, and amputees have reported it feels like I've lost my arm all over again. So definitely.
So what you said is don't give it to them in the first place.
No, but it underlines the importance.
If you don't give it to them, they won't use a prosthesis in general, and so I guess you could argue whether.
So my question is, your claim right now is that people won't use this prosthesis if they don't have this.
Correct.
Is that true?
So I would argue that there has been a bunch of research studies that have looked at why amputees abandon their prosthesis. One of the top reasons is that the top reason is aesthetics. It doesn't look like an arm. It looks like a tool, and it isn't cool.
And this wouldn't affect that.
Right, exactly. In terms of functionality, it is what you mentioned.
But what percentage of people abandon their prosthesis?
I have that. It's about 60% of.
60.
Yeah.
Impressive number.
Time for another question?
What do you see as the reimbursement pathway? Is this novel, or does it attach on to another pathway?
It's the advantage of this approach is that it's going to be inexpensive and cheap and easily variable. So we are the aim is to target both the subject, the user of the prosthetic device, and also the insurance companies if they want to pitch in, because it's really cheap and it's not a huge burden on the economic.
What's really cheap?
So yeah, we want it to be around $100 to $150.
Okay.
So $150, right? How many people in the country or in the world could this potentially go on?
That's a good question. So that's why I wanted to emphasize that we're not focusing on feedback delivery or development of a prosthesis. Those two on their own are fairly expensive. We just want to make sure that our solution doesn't tack on an additional prohibitive cost.
Right, but this may not be a market. This is good for mankind. But if I take, $100 is, your cost of goods, right, or probably whatever, say 50% of that, right? So you're saying I've got a $50, I'm making $50 every time I sell one of these to the, 20,000 people that may get it. It's just not a fundable market. It's a great for mankind thing, but it's not a business, unless I'm wrong.
Sure. So the only additional other argument that I would make is augmenting physical experience with sensory feedback isn't necessarily a novel concept. So I could envision, even though this is not our expertise area, I could envision Haptic extending towards other disease conditions. So diabetic neuropathy, where there is nerve damage, the patient or the subject is not disabled, does not require a prosthesis, but if you can augment with some sort of sensory feedback, or rehabilitation for stroke rehab, again, a place where sensory feedback is relevant and there's no additional purchase or no additional learning that's necessary.
That opens your market significantly.
Exactly.
And if you'd want to make sure that insurance covered it, you want to make sure that
absolutely.
Yeah, I mean, I was going to say, the feedback here is charge more. I mean, because when you think about being able to feel, from an amputated limb again, it's a lot more value than $100.
Sure.
There's competitive. You will get some competitive dynamics in there and copycats and Me Too's, but I think about the additional kind of data and as a platform and what else you can do and leverage that in other spaces. It's interesting.
Absolutely. Thank you, Haptic. Thank you. All right, we've come to our fifth of our 6 teams. Let's see. So next, I would like to introduce to you, representing SenseTech and Planexta, Irene Brinker.
She's just a girl and she's on fire. Hi, ladies and gentlemen. Thank you very much, all the other competitors. Honestly, I'm really inspired by several of you. And thank you for the judges for sitting through 6 whole presentations. But I wanted to introduce myself. My name is Irene Brinker. I'm not a doctor. I'm not a scientist. Most people ask me, what am I doing in the healthcare space? I have over a decade as a patient. I'm a cancer survivor. Before that, I was the daughter of a cancer victim, the niece of a cancer victim, the granddaughter of a stroke and heart attack victim. That's why I'm doing what I'm doing right now. In fact, I'd like to introduce you to some people. These are my grandparents and their friends. They were resistance fighters in World War II, in the Soviet resistance. They were saving people. They were saving lives. The reason I point this out was because my grandfather, a war hero, had 8 strokes after he moved to America. He was very excited to be an American. Unfortunately, he got not only the best of America when we moved here, but also the worst. 1 in 3 adults in this country every single year, about 86 million people, have at least one type of cardiovascular disease. Heart diseases and strokes cost America nearly $1 billion every single day in medical cost and lost productivity. Over 735,000 Americans have a heart attack every single year. And like my grandfather, over 210,000 of these are repeats. So what do we do about this? How do we help these people? Obviously, I'm not the first person thinking about this. Our products. The first one is the SenseBand. This is our consumer, fully autonomous electrocardiogram and heart rate variability monitor for one limb. What I mean by autonomous is that unlike anything else that's out there that does go on one limb, you don't have to, and this isn't it, this is the next one, but you don't have to actually touch it with the other hand for it to take a reading. It does that by itself. That data can already be sent through the consumer app, which reads stress levels, emotions, recovery rates. That may not seem like a whole lot, but as a cancer patient, I was told every single time I went to see a doctor, you should really look into managing your stress levels. A lot of what's in this product is based off of my experience as a patient. And it can help everyone else before they become a patient learn how to make behavioral changes. Now, the data from the consumer sense band can already also be sent through Precise, which is our medical electrocardiogram and heart rate variability translation platform. This is already live in Asia and Eastern Europe. Here we have to get HIPAA, obviously, and FDA clearance in order to run this. But this is the start of our remote care ecosystem. For that, we've already been named one of the top 20 connected health solutions of 2017. And we won the Silver Hammer Award for the Sense Band, Fraunhofer IZM Engineering. Now, what I'm wearing here, it looks ugly right now. It's an ugly prototype, but it works. It's a constant blood pressure monitor built on top of the ECG technology. It's continuous, and I'm happy to show people a video. It changes all on its own, meaning that I don't have to do anything in order for you, my doctor, to actually see what's going on and see the relevant changes that are happening. We also have an accurate blood oxygen saturation monitor. We believe that combining these technologies along with that remote monitoring platform of Precise, it'll give us an opportunity to be able to see, from what we understand, ischemia and myocardial infarction up to 2 hours before they happen, so that the doctor, caregiver, even the patient themselves has enough warning, enough time, unlike my grandfather, to actually get somewhere and get the help that they need. Now, this is a very competitive landscape. There's a lot of competitors who do blood pressure, people who do ECG. Some of them have remote monitoring platforms, but there isn't anyone else who's been able to put all of these things together in one wearable. We call ourselves a dream team, and we are on a mission to save lives, but that dream didn't start with us. I showed you earlier that my grandparents were in the resistance. They fought with guns. About 70% of our team is grandchildren of the resistance, that same resistance. Only we fight with science, and we have a very different enemy. We are SenseTech and Planexa, and we're on a mission to save lives. Who of you would like to join our mission?
I was just wondering if you've talked to any of the other, like the Apple Watch or any of those folks, to see if they wanted to adapt your technology and use it in their platform, just so that you don't have to reinvent the wheel.
Absolutely. That's a fantastic question. We haven't spoken with Apple yet. They've literally just partnered with AliveCore with their Cardioband, which requires a second hand. The difference is that ours is fully autonomous. But we have opened up conversations with other wearables companies. Our fear is getting benched too early with people trying to do an exclusive licensing agreement. So our goal is to sell, or actually to have in active use 1 to 300,000 sense bands before we license the ECG technology into the big brand wearables and completely shift our focus to medical. But we've already started with medical as well. I'm currently at the Texas Medical Center Accelerator, so hopefully, we'll be getting into some trials and pilots and all that fun stuff. But we need funding.
So what are you doing with the EKG data you're collecting?
So right now, for the U.S. market, we're kind of in a holding pattern. So the data is actually stored in the device. The customer, because at this point it's a consumer product, has it in their app. And it is built right now where they can actually send it to their doctor. What I think we're going to do for the U.S. market, because we don't have the FDA and the HIPAA, is create a subscription model where, let's say for $9.99 a month, they can have this data, then they can present it to their doctor. It's still constant monitoring while we go for those but we can't store it.
No, yeah, I guess, you know, like if you're collecting all this, like at some point, like, you know, I mean, just collecting the signal stream, you know, it's useful, but like not actionable.
Yeah.
And like, you know, presenting me as a patient with the ECG reading on my phone is also not useful. It's hard enough to read it in med school than it was, like, you know, as a consumer. Like, but it seems like, and then if you send it to the physician, you know, the likelihood that they're going to ever look at it is low.
It's not just ECG. So the Precise actually translates it and gives a cardiovascular risk assessment. And I'm happy, after this, I have my computer, I'll show you some sample reports. Precise also works with any electrocardiogram that you want to use it with, not just with our devices. The goal is to have more general practitioners, more, you know, nurse practitioners in areas where they don't have a doctor, being able to perform more electrocardiograms so that they can send it to someone else when there's a problem.
See, it's not an electrocardiogram, though, right? What it is it's explain to me what it is. At best, it's a single lead EKG. So at best, you can get rhythm or rate or something out of it. Is that correct?
So what we're actually getting, it is a one lead, and I can show you in comparison what we're doing is amplifying and magnifying the R peaks, the top of the ECG. And we're using that to read heart rate variability, because we're not just getting the R peaks themselves, we're getting LF, VF. I could show you that data as well.
I totally agree you can do that. So I guess going
It's not to replace the doctor.
No. But going to his question, why does anybody care?
Mm-hmm.
Okay, if I'm a payer, if I'm a patient, if I'm a physician, what is your measurements adding to the diagnostic ability that, you know, that I need now?
Yeah.
Rather than it's a nice to know thing.
Constant monitoring, and I'll tell you why. So let's say something does happen and someone collapses, right? Mm-hmm. Right now, and they do have this, and they have Precise. Before they ever get to the hospital, and of course this is in the future, we have to get approval.
Well, they're
that,
actually dead at that point.
Well, if they're having sudden cardiac arrest, right? That's true.
Yeah, right.
But not every heart attack is.
But how would you know? How would your single lead EKG tell me that I'm having a heart attack?
So that wouldn't, but this would.
Why?
Because what we're doing, and we can talk about it more offline, we recently filed the patent between blood pressure, blood oxygen saturation, and heart rate variability, as well as that one lead ECG where those R peaks are, the shortening of the PR intervals, as well as blood oxygen saturation, can help us understand if someone's going into MI2. We could also read ischemia, signs of ischemia, through heart rate variability, which is the difference in time or variability and frequency in heartbeats.
Heart rate variability gives you changes in autonomic tone. It doesn't tell you anything about ischemia per se in that thing. But let's assume you can, okay? My question is, one of the big problems that, like, there's a device called CardioMEMS. Mm-hmm. And that device records invasive pulmonary artery pressure continuously. And it's been shown to reduce admissions, and doctors hate it. Doctors hate it because you get alarms and reports and tons of paper that mean nothing, and I don't have the time to go through it.
Yeah.
So the question is, you're generating reams and reams and reams of information. To your question, how is the doctor supposed to sort through that information with everything else they have going on? What are you going to provide that will make it easier for the healthcare system to?
So that's a fantastic question, right? I wouldn't expect the doctor to sit there and go through all of this. But how do we really help these patients? How do we lower people's risk? Maybe it's from the side of the insurance company, right? Because what we have, it's not enough to tell you exactly what is wrong, but it is enough to tell you that something is wrong, right? And knowing that something is wrong and getting someone to a doctor so they can figure out what it is, isn't that part of prevention?
So I'm going to put on Howard's VC hat,
yes,
if I can. But help me understand, is this a consumer device? Is it a device that you wear once something has happened? And you know, in many ways, who pays for it? Because I'm sort of struggling. It's pitched as a consumer device, but it sounds very clinical.
Great point. I apologize for the confusion. That's because we have several devices. So the first device is a consumer device. And that's already live. We've already sold over 2,000 units. Consumers are interested in it from the side of stress management, from the side of emotional management. There's a social network where you could see how other people that you've chosen to share each other's information with, like your husband, your kids, are doing. So we found, based off of surveying our crowdfunding customers, the reasons that people are interested in that is, oddly enough, more so from the emotional standpoint. So that's its own product, but that is still the basis for SenseBand Medical, which initially is going to have to be a medical device. Because how do you get a consumer who thinks there's nothing wrong with them to wear something that could tell them about something that could be wrong with them? It's not going to happen. So by starting that with medical, starting with the SenseBand with consumer, and then in the future being able to bridge that gap, right? Bringing them together so we can bring more of the medical products once it's proven, validated, FDA approved, very consciously into the consumer device, at which point, once it's already being used as a medical device, the insurance companies are already familiar and aware of it. At that point, the insurance companies, understanding the preventative benefits that that could provide, at that point, we have the conversation with them. Or maybe we build a call center of nurses, right?
So but how are you proving, are you going to do a clinical trial to show that there's an advantage to your particular measurements over existing measurements?
Well, right now, there's a reason we already know that people are taking these measurements. Why are there so many other companies that are doing one measurement or the other? We're just the only ones who get 4 from one.
But most of the companies are doing it for consumers to kind of enjoy, and it's very different doing it for using the medical model, so that you get into a whole different world.
Yeah.
And you seem like you belong more in the consumer world than the medical world, just from your background and
Yes.
your comfort level.
So me personally, yes, I agree with you completely. Medical is something that's brand new for me. But my co-founder has over 13 years of managerial experience at Genzyme, Merck, and Novartis. So he has a little bit of that background. And one of the reasons why I'm at the Texas Medical Center Accelerator is because I know that that's a gap in my understanding and knowledge. I want to bring in more people. Now, we have in Eastern Europe, I have a whole slew of doctors, but that does me very little good here in the United States. So I'm looking for doctors who want to work with us, who want to advise us, because I know that this is a gap for me. I don't have this knowledge. I want to work with someone who does.
So, do I have time?
Sure, one last question.
I guess so how are you thinking about the impact of false positives?
Well, I think a false positive in this particular case is much better than a false negative. I personally, as someone who did not know that I had a tumor for probably long enough for it to double or triple in size, I would have much rather gone in or thought that I had something and then found out that I didn't, because that's a celebration, versus thinking that I have nothing and then all of a sudden there it is, right? I think that that's more forgivable from the side of a patient. And I could be wrong. But for me personally, I'm willing to get called in.
Great. Thank you, Irene. Great job. Okay, we've come to our last team. So a warm welcome. Don't be too tired. I know we had a lot of food and drink and it's getting late, but an equally enthusiastic welcome for representing Proxima, Talal Ali Ahmad.
Good evening. I'll try to keep you awake for the end of the evening. I just want to start about how Proxima started, augmented reality for surgery. 2 years ago, and I still travel with my co-founder on a medical mission outside the US to Latin America and Africa. We do the cleft lip surgeries. And every time we travel, it's the same scene. Doctors are waiting for the US doctor, European doctors to come in, show them how to do the surgery. The kids are waiting anxiously, and they cannot do 200 surgeries in 1 week. They do 50, maximum 70. So the idea was we put our head together, myself and my co-founder happened to be a plastic surgeon. We need tools for this. We need something to teach the doctors how to take care of the kids after we leave. And that's why we came up using augmented reality to come up with a platform to assist surgeons, mainly overseas in an underserved country. But we came back here, we said there's a similar problem in the US and the West. So the problem we're trying to solve is in the US, when you have a multiple discipline team working together, coordinating surgery and have a specialist available all the time, it's always daunting effort. And delay surgery, make the patient wait. Lack of access to specialists during surgery, like if in the middle of surgery you need to talk to a specialist. It's very hard to get someone down to the OR and give 5 minutes of review and go back. It takes an hour sometimes, and the patient, they have to rotate the operating room. The distribution of a population and the medical specialists is not always the same. You have population in different area, they have underserved areas, so that's always a problem. And also centralized services mean patient has to travel for medical service. So just a number up there from, and the surgical, this is the US only, in Europe and overseas is almost a similar number. Cost of readmission and revision of a surgery costs about $4 billion a year in the US by itself. Revisions, about 20% of people come back for the hospital for medical revision, surgical revision after that. So to do it right from the first time, it will save money and improve the healthcare delivery system. Plus, revision always never comes back clean or right. It then costs more money. So the solution is to increase access to surgical resources, reduce cost for readmission and revision, improve patient outcome, and improve surgical skills. And on the next slide, I'm going to show a video of our application in the use, just a small, about 10 seconds, and we can talk about it.
Albert, from here, you go inside.
So
it has to go
we have a surgeon using Da Vinci robot performing surgery, and his colleague sitting on the 7th floor, pointing to him what he needs to do in the operating room, without leaving the office, without scrubbing. And this is simple. We do a lot with the augmented reality. We do the image overlay. We do measurement on the screen. We can input data from different libraries and resources. This is a shot of the screen. You have the video in the middle, and you have the data coming. And also, if you have people watching, you can collaborate with them. So the market we're addressing, I mean, it's the same software. It can be used across different markets. It's the clinician. For telesurgery, telementoring, they can use the software. We record everything for them. We store it, have it available. We keep statistics on it. Medical device company for telementoring, support for the surgeon at any time with a click of a button. Medical school to teach the upcoming surgeon to become better at what they do, and by having always mentor available for them. Our platform is cloud-based solution, is a HIPAA compliant, secure, and also we have a few patents pending on the application itself. We run on any device. We can be operating system, could be a tablet, and could be a laptop, wearable also. Oops. And then also we have a device, a medical compliant device can go in the operating room in case we need it, if the hospital decides to go that route. From competition, there's a lot of things happening in the medical field today between AI, AR, telemedicine, telehealth, and everything. So we sit in the middle. We bring a lot of feature in one platform. So our platform become the go-to platform during pre-surgery and during the surgery. So one click of a button, you get a lot of information. And I want to emphasize, we focus on augmented reality as a real surgery. We don't convert to 3D or animation to keep things real for the viewers. Again, I think we're out of time, but the team is a combination of medical team and also engineer put our head together to come up with a product. Thank you.
So are you advising, like, will someone be in one country and someone in another country can be helping them with surgery?
Correct. So our platform set in the middle, connect them, make them work together using augmented reality to assist in the surgery.
In the U.S., aren't there rules about this state to state? How do you get around somebody in one state, practicing medicine in another state? If you will?
So that's used to be about 5 years ago. some states right now allow we call fast track to cross license through the what we call the state border line. So between Massachusetts and New Hampshire, there's some leeway for that. Other state, they move faster. If you go like toward Minnesota, Washington State, they are moving fast to that model because they need the expertise to be available instead of having the patient wait.
But most don't right now, right?
No, but it's moving faster than we think, which is good for us.
I'm sorry.
Oh, no. How do you actually quantify the value that you're creating? I'm not even talking about like the payment model, but how do you know that things are getting better, and are you going to be able to really demonstrate that in a compelling way?
Well, so from talking to existing customers, it's the readmission revision is the value. Look at it, because when they get a patient, they have to do a revision, do the surgery again. For them, that's a bottleneck and an issue for them. They can always guarantee that. So if they can cut the cost on that model, that's what they see the revenue. If they can streamline, the patient doesn't have to pay or wait for the surgeon to delay the treatment, that's also the way they look at it, at revenue. Or
do you have any indication that you will be able to impact revision?
Yes, so what we did during the trial in the US and we did in Europe, so there's an average cost saving on a surgery for someone to dial in like this. There's at least a $3,000 to $4,000 saving per procedures for doctors to come in, to check in, spend half an hour, come back out and go to his surgery. There's about $2,000 saving. And if they add up, if you have a hospital with 25 rooms, if you use that 5 times, they add up and they can see the saving there.
So I'm just trying to understand the business model. Mm-hmm. So you have a person in one operating room, somebody sitting in an advisor sitting room. Is that advisor your employee?
No.
Okay. So you're providing the hardware for the different...
We're providing the software to make them talk to each other.
The software to make them talk to each other.
And the doctor are working together, could be directly, or they can find each other through their network.
And who pays for it?
So it usually is the operating doctor entity or the doctor work is paid for it.
Is your model a per use basis? Do they buy just the package? You know, it's
a licensed model. So each doctor or department have a license for all the surgeons in their hospital, and we charge monthly fee or annual fee usually for the
rather
department.
than a per case fee or something like
well,
that.
Well, outside the U.S., per case is more famous than the U.S. Outside the U.S., they want to pay per case. In the U.S., they want to pay flat fee. I use it as many times as I want. I give you a licensing fee.
Okay, and
so,
I'm sorry.
I was going to say, what's the hardware configuration that's attached to the surgeon and in the room?
Okay, so we've done a lot of work. We started with Google Glass early days, and we tried everything. So the surgeon today are resisting wearing something on their face if the surgery is going to go for 3 or 4 hours. They can wear the HoloLens, and they can wear the Google Glass for 20 minutes, 30 minutes procedures. What we did is we took everything and we put it on the wall, camera above the head, or connected to medical imaging software, and display everything in front of the doctor or in front of them in the bed. So there's nothing the doctor has to get used to it or have to go training for it for 6 months to use it.
So if I'm trying to do surgery in this field, mm-hmm. and I'm looking down here.
Yeah.
So you're saying I have to look up and look down, look up and look down to try and figure out what you're telling me.
And surgeons do that today. If they have to look at an X-ray, they can look up and down all the time. They still do that today. I can put it on a wearable for you. It's up to you if you want to wear it for 3 hours. It's available. We support it.
And technically, if you're going to use this outside the U.S., granted, a lot of places have better bandwidth than we do. But if you're going to use it in the places that are most likely to have this, that barely have electricity, much less bandwidth, what is the rollout? Is that a theoretical market or is that a real market?
No, it's a real market. You'd be surprised when you tell the doctor in an underserved country, we're going to give you technology allows you to have access to specialists. I mean, we did it in Peru. And the minute they found out what we're trying to do, we went from 2 meg per second link to 20. They open up for us. There's the resources available. They make it work if there's a benefit for them.
So do you actually connect them with the experts? Like how does that get negotiated?
Well, now I've been asked to connect with an expert, and the way we're doing it right now, we find a hospital, we're going to work with overseas hospital, we put them together. And some of them in their NGOs and some of them for paid services. It's up to the hospital.
And who? What's the competition? Is there a lot of competition in the training space in particular?
Well, there's a lot of competition on VR, virtual reality, where people create a 3D model to show the doctor what he needs to do. But the VR is still early stages because you have to have a lot of intelligence behind it. If you're cutting your hand like straight line, doesn't matter. You cut 100 times, it's going to always show the same result. Maybe 10 years from now, they have all the AI behind it. So the competition mainly right now on VR and training purposes for us is to real-time surgery between two doctors.
So from the practical business point of view, what's been the adoption of this? If I was going to invest in you, you know, like what's your ask? How much would you need to get up to a point where you have rapid adoption or more widespread adoption? You know, what's your installed base now, and where do you anticipate it to go to?
So the adoption rate goes by how many operating room we're in. So average hospital, about 10 operating room today. We say this is the average one.
No, but how many do you have installed today?
Today we have 5.
Okay.
5.
And what is your goal for the next, 1 year, 2 years, 3 years?
For the next 2 to 3 years, we're looking at about 400 hospitals to be in place.
And do you need a lot of additional, is it all marketing money, or do you need any development money still?
No, the development, right now, we're in the market, we're selling. The money we need is for sales and marketing, get our name out, because if you're working with doctors, you have little time to connect with them.
Do you need regulatory approval for this, or no regulatory approvals needed?
So we have different features. We didn't show all of them. The first couple features, we don't need regulatory approval. When we start working with image overlay and guidance, then we need the FDA clearance, which is not hard because we're going to reference other technology right in the field.
So what is the key differentiating points between Skype, right, that you can draw on? How much better is it?
Well, let's talk about the top things too, HIPAA and security. So we're up there where Skype still have way to go to that. That's one.
They'll get there. But.
So it's Skype today, if you have this in your phone in front of you, is the handling of the Skype in operating room is very hard. Also, you have to worry about the images, if the image is flipped or not, because if you tell them right or left, this sort of stuff. What also we connect to medical records, so we can pull information on the fly. We can pull information from the PAC system for medical imaging. We can connect to any medical imaging device to become the camera for us, and we have multiple cameras in the room. And that's all with the click of buttons. You don't have to do anything in the room.
Great, thank you.
Great, thank you very much, judges. Awesome, so that is our final presentation. Judges, please fill out your score sheets now, and we will be collecting them. For many of you who have been to our events before, we don't have a long deliberation. We have the judges fill out score sheets, we plug them in, and we bring you the winners right away. We don't want to keep you waiting. But that does take a few minutes. So before we announce the winner, I would like to take an opportunity here to thank many of the people who helped us make this event happen from the MedTech Boston and the Boston Scientific teams. So, assuming I can read it. First, many of you have interacted with her over email. She's been here throughout the event. She really makes everything happen for us. Please, warm round of applause for Abby Ballou. Abby, stand up, stand up. And then from our Boston Scientific team, who have really, we've been working for 9 months, and this is the culmination of a lot of preparation and work. I am going to name the 5 members who have worked with us to make this happen. We have Kate Taylor, Dr. Mark Bowden, Amanda Gephardt, Dr. David Knapp, and Randy Scheistel. Thank you all. Great. Okay. And then, okay, good. Before we announce the winners, and not to make you wait too long, we would like to bring up onto the stage Sandra Nagal, the Senior Manager of Digital Health IT at Boston Scientific, to give us some closing remarks. Sandra. Did I get your name right?
That's right. Thank you so much. I think you can hear me. I can hear myself.
So I just don't want to take too much time from you. I know the judges are already done. This was pretty easy, and it was not as easy last year. So I want to open a little bit of a window into what we do at Boston Scientific in digital health. We are very excited always to be here, but it's important for all of us to also share what we're doing, and we're so excited about our capabilities. So first of all, just wanted to thank Medstro and Google and everyone else who has been involved in this event and great challenge that we hold every year, and we're excited to doing this always in the future. But here's a little bit of a story of what we're doing. Just want to share some forward-looking statements, disclaimer. But let's go on. So we have very important mission and values, and they're very, very dear to our heart. Some of them that I want to call out that are very relevant for digital health are caring, meaningful innovation. We want to always provide the best solutions for our end users, for our patients, physicians, nurses, and caregivers. We care a lot about our global collaboration and diversity and winning spirit. We want to always win because it's very important that we bring up the best solutions in front of our end users. So I'm sure that you all know a lot about Boston Scientific. It's been around for such a long time. What we do that's really unique is we have an opportunity to actually touch so many different chronic disease states. The majority of them actually, including heart disease, cancers, and urology, men's health, women's health conditions, and chronic pain, neurodegenerative diseases, neurological diseases. What's really important for us is to provide solutions around the products that we have, and that's why we are excited about the digital health opportunities right now. And we've been doing this for many, many years now. The number that I want to call out is we touch 24 million patients each year. Now, you might think that a big company like ours with 27,000 employees might be less entrepreneurial, but it's not true. We actually have a lot of capabilities like the Innovation Fund, internal, external incubators. We've been really spearheading our agile development capabilities in the last year or so. But these efforts have been going on with our excited and really powerful and talented teams for many years now. So I just want to give you a little bit of an overview of each one of these areas that are exciting for us and just really provide so much for our employees and our patients, physicians, and everyone else in their ecosystem. We have Imagine If. It's an innovation fund. It's dear to our president and CEO, Mike Mahoney. I've seen it born. I've been so excited to see it grow over the last 4 years. We're in our 5th year now. It provides an opportunity for employees to actually act like a startup. So they form teams, they submit their ideas, and then for a year they get seed funding and they can develop them further and then transfer them forward to fruition. We've had 1,500 plus submissions and selected 45 projects. What's really important for Imagine If is that we don't only innovate on products that are something you can hold in your hand and technologies, but we innovate on the ways we deliver healthcare, on solutions, and the way we operate and kind of provide better efficiencies in healthcare. We also have external incubators. One of them is an Israeli incubator that's a partnership between Boston Scientific, Intellectual Ventures, so a couple of ventures firms, and also hospitals in Israel. This is just one example of how we reach out globally and provide a network of opportunities with startups that are really intelligently addressing needs outside of the US. So that purview is extremely important for us. So we continue reaching out globally and innovating globally as well. We also have created a digital health incubator internally. It was completely focused on digital health, and it's been a program that's been running just for the last couple years. We sponsored so far 3 product teams, and we have created 2 minimum viable products that have been iterated over time. Very importantly, we've established throughout this journey agile DevOps capabilities, which we are quite proud of. It's our newer capabilities. So briefly on the agile product development capabilities, we are forming teams that are enabled and empowered. And they have a balance of 3 distinct areas, which is product ownership that works on lean startup principles, the design that really is focused on the end user, and everything starts with the end user and ends and iterates with the end user in mind. And then engineering that's focused on extreme advanced types of programming principles that's distinguished and something that's used in the best companies, software companies out there. So we're very proud of this new capability that we've created. We are committed to iterating small pieces of product instead of creating a large product. And we're also able to ensure that we introduce compliance into every small piece. So we focus on top features that we can test with our users and then iterate and create the most valuable, the most high quality product in the end. So these are some photos of our Agile teams. You might have seen some of them around today. We're very excited to have these teams, and we're excited about the opportunities that these teams can provide to us. They're small, they're located in the same space, empowered, autonomous, excited. They practice lean, agile DevOps. They stay with the product for a long time, and they're really committed to making sure that this is most important product for the end users. And they, of course, are very focused on user-centered design. Just a tidbit of one of the products that we're very proud of at Boston Scientific. It's called HeartLogic. It combines multiple sensor data, so big data, to provide one composite alert. This alert is really remarkable. This capability is super remarkable because it can provide alerting for cardiac decompensation about 34 days in advance of the event. That's 1 month ahead of the event with 70% sensitivity. So we look forward to developing more of these kinds of solutions in the future. Finally, we are excited about the future. We continue working on understanding new technologies like AR, VR, blockchain. Anything that we've seen today, it's been exciting just to see how many teams are thinking forward. And we're trying to do the same, but the way we do this is through collaboration with our teams internally, with all of our functions that support digital health, and also with all of the external entities like the Connected Patient Challenge and other partners and collaborators that we can have in the future. We've been really, really lucky to be part of this particular event every year. We have some success stories. We've had 3 winners so far: WatchRx, Pillow, the adorable bot, and Medumo last year. And we have one really nice story about Pillow. We've had so many teams work with them, the winners from last year. They've had a great time brainstorming on new types of ideas, and we even brought them with one of our divisions to one of the biggest conferences that we have attended last year. So they were able to brainstorm with healthcare practitioners. So we continue those conversations. We learn as much from them as they learn from us. So we hope that these collaborations can continue in the future. Finally, thank you so much for this beautiful event, and thank you and congratulations to the finalists. I think to us, you're all winners, and thank you for really doing so much for advancing healthcare and providing large value to our patients and everyone else who supports them. Thank you.
Thank you. So we do have our winners. We have tallied the votes. Thank you, judges. We're going to bring up the second place winner first, and then the first place winner. Before we do that, I wanted to let everyone know we have food and drink with this desserts now outside. If you've had the wonderful appetizers, we've now switched to desserts. That will be available through 9 o'clock, so you don't have to run out and eat it now. But definitely do try it. The Google team makes amazing food. So, all right. So without further ado, wait. Oh, yes. Please join me to present the awards. And wait, the awards have been secretly hidden in the little pack. Yeah, here they are. Okay. All right, there we are. Okay. So our second place winner, please welcome to the stage, Proxima. Congratulations. Okay. Got to get in the picture. Okay. And without further ado, our first place winner, the overwhelming choice of our judges, AMI Aware. And then we want a photo with, okay, there we go. Congratulations. Want to make sure there's nothing left on here. Okay. I'm out of paper, so I think that's the end of the event. Thank you, everyone, for joining us. Food and drink outside. Join us next year.
rolling on the 110, southbound. Got my Chevrolet 6K, drop top. Ran into my man Hymno. He had his Mustang.